This is Chapter 12, Schizophrenia. So we start by looking at what schizophrenia actually means. People with schizophrenia experience psychosis, and this is defined by a loss of contact with reality. It includes symptoms of hallucinations, false sensory perceptions, and/or delusions, which are false beliefs. It may be substance-induced or caused by brain injury, but most psychoses appear in the form of schizophrenia. So schizophrenia spectrum disorders include a number of schizophrenia-like disorders that are listed in the DSM-5. Each is distinguished by particular durations and sets of symptoms, and all bear a similarity to schizophrenia. The most prevalent of these disorders is schizophrenia. So the DSM-5 criteria for schizophrenia is that there is a continuation of symptoms of psychosis for 6 months or more, and that there is deterioration in social relations and the ability to care for oneself. Specifically, for 1 month, the individual displays 2 or more of the following symptoms much of the time: delusions, hallucinations, disorganized speech, very abnormal motor activity, including catatonia, and negative symptoms. At least one of the individual's symptoms must be delusions, hallucinations, or disorganized speech. Individual functions much more poorly in various life spheres than was the case prior to these symptoms. And beyond this 1 month of intense symptomology, the individual continues to display some degree of impaired functioning for at least 5 additional months. So schizophrenia affects approximately 1 in 100 people in the world. It creates enormous financial and emotional costs, and it appears in all socioeconomic groups, but it is found more frequently in the lower economic levels. And the downward drift theory is the idea that it could be the socioeconomic conditions themselves that are contributing to the schizophrenic symptoms, or vice versa. It's diagnosed equally in men and women, and it differs diagnostically by marital status. So 3% of divorced versus 1% of married people experience schizophrenia. This gives you kind of a visual for the socioeconomic breakdown for schizophrenia. Again, in general, mental health disorders do seem to disproportionately impact people who are under the poverty line, but we can see that especially clearly with schizophrenia. So looking at the clinical picture of schizophrenia, it does produce many clinical pictures. The idea here is that the symptoms, the triggers, the course and treatment can vary greatly from person to person. Some clinicians actually believe that schizophrenia should be a group of distinct disorders that have similarities. The symptoms can be grouped into 3 categories: positive symptoms, negative symptoms, and psychomotor symptoms. For positive symptoms, this does not mean good or bad, but it refers to pathological excesses. So this is bizarre additions to a person's behaviors. The most common are delusions, disorganized thinking, heightened perceptions, and inappropriate affect. Delusions are strongly held ideas with no factual basis. Disorganized thinking and speech refers to illogical thinking that can create confusion and negatively impact communication with others. This can include loose associations or derailment. This is rapidly shifting from one topic to another, believing incoherent statements make sense. Also neologisms, made-up words that have meaning only to the user. Perseveration, repetition of words and phrases. And clang, which is communicating in rhyme. Heightened perceptions and hallucinations refer to sensory overload, which makes the individual highly distractible. This also includes hallucinations. The most common are auditory hallucinations, and again, these are all sensory experiences that don't have any actual basis. Also somatic hallucinations, so feelings that there is something happening within the body. Tactile hallucinations, so feeling sensory experiences on the skin. Visual hallucinations, gustatory hallucinations, which is feeling like you are sick based on food. Sometimes it impacts the way that taste happens as well. And then olfactory hallucinations, which is smelling things that, again, don't have any actual sensory basis. And then inappropriate affect are when the emotions are unsuited to the situation. Negative symptoms include pathological deficits. So these are characteristics that are lacking in a person. The most common of these is poverty of speech. So this is a reduction in speech or the content of speech. Restricted affect means that the person may be blunted, less emotional in their display than most people, or having a flat affect, meaning that there is almost no emotional display, or anhedonia, where there's a general lack of pleasure or enjoyment, and you may remember this from previous disorders that we've discussed. And then loss of volition. So avolition means that there's apathy, a feeling that the energy has been drained, that the interest in normal goals is no longer there, and that they're unable to follow through a course of action. And then ambivalence. These are having conflicting feelings and about most things, not specific issues. And then social withdrawal, so attending only to their own ideas and fantasies, which further distances them from reality and creates a breakdown of social skills. For psychomotor symptoms, these are awkward movements, gestures, facial expressions, etc., that have a private purpose. So catatonia, which we've talked about previously with other disorders, is a pattern of extreme psychomotor symptoms found in some forms of schizophrenia. In catatonic stupor, the individual stops responding to their environment. They remain motionless and silent for long stretches of time. In catatonic rigidity, the individual maintains a rigid, upright posture for hours, resisting efforts to be moved. And with catatonic posturing, they assume awkward, bizarre positions for long periods of time. With catatonic excitement, we have kind of the opposite end of the spectrum for the previous three. So this is moving excitedly, sometimes wildly waving arms and legs. So we'll look now at the course of schizophrenia. Schizophrenia usually first appears between the late teens and mid-30s. Many sufferers experience three distinct phases. So the prodromal phase, symptoms are not yet obvious, but there is a deterioration that has begun. Social withdrawal, for example, communication oddities, strange ideas, and having little or less emotion. And then there's the active phase. During this time, the symptoms are apparent. Sometimes they're triggered by stress or trauma. And then there's a residual phase. So this is a return to the initial phase. 25% of people who are diagnosed with schizophrenia will recover completely, but the majority of people who receive this diagnosis will have residual symptoms. Many researchers believe that a distinction between type 1 and type 2 schizophrenia helps predict the course of the disorder. So type 1 schizophrenia is dominated by positive symptoms, and type 2 schizophrenia is dominated by negative symptoms. We'll look now at how the different theorists explain schizophrenia. Biological, psychological, and sociocultural theorists have proposed explanations. Biological explanations have received the most research support so far. So in the diathesis-stress relationship, which we've seen in previous disorders, people with a biological predisposition will develop schizophrenia only if certain kinds of stressors or events are also present. Following principles of the diathesis-stress perspective, genetic and biological studies of schizophrenia have dominated clinical research. Key roles of inheritance and brain activity and important changes in treatment have been reported. Some genetic views and factors that are supported by research. Relatives of people with schizophrenia are more likely to have also had schizophrenia. Twins tend to be more likely to have the disorder than siblings who are not fraternal twins, or identical twins. People with schizophrenia who are adopted are more likely to have biological relatives with schizophrenia. And then there's a genetic linkage in molecular biology that's explored as well. Some of those biological abnormalities include genetic factors that can lead to the development of schizophrenia through two kinds of potentially inherited biological abnormalities. Those are biochemical abnormalities and abnormal brain structure. So under biochemical abnormalities, the dopamine hypothesis has been challenged by atypical antipsychotics, which I'll talk about shortly. And then the abnormal brain structure, enlarged ventricles, so abnormalities in hosts of the brain structures. Some studies show that people with schizophrenia have relatively small temporal and frontal lobes, as well as abnormalities in brain structures such as the hippocampus, the amygdala, and the thalamus. As always, I'll just point out that we don't know which comes first here. The brain abnormalities may result from exposure to viruses before birth that may interrupt brain development. They may remain quiet until puberty or young adulthood when activated by changes in hormones or another virus. The evidence for this has been shown in research with animals. Also, there's an impact, or research rather, that we can see with winter birth rates and the virus infection rate of mothers, and antibodies to certain viruses of people with schizophrenia. From the psychodynamic perspective, Freud's perspective first, schizophrenia develops from regression to pre-ego stage of primary narcissism and efforts to reestablish the ego control. Near total regression leads to self-centered symptoms such as neologisms, loose associations, and delusions of grandeur. And then attempts to reestablish control and contact reality may influence development of other psychotic symptoms. From Fromm and Reichman's perspective, again under the psychodynamic umbrella, schizophrenogenic mothers, who are mothers whose parenting patterns create confusion for their children, may set the stage for schizophrenia. The psychodynamic explanation under contemporary theorists, however, looks at Freud and Fromm and Reichman's views as unsupported by research. From a cognitive explanation, they agree with the biological view that the brains of people with schizophrenia produce strange and unreal sensations during hallucinations and related perceptual differences. So what they suggest under this view is that the features that emerge are when the individual tries to understand these unusual experiences. Essentially, this is referred to as a rational path to madness. So because of the symptoms and the experiences themselves are bizarre, the conclusions that are drawn about them are also incorrect and bizarre. From a social-cultural perspective, theorists believe that three main social forces contribute to schizophrenia: multicultural factors, social labeling, and family dysfunction. So under multicultural factors, there are some ethnic differences. 2.1 versus 1.4% of African Americans to white Americans are diagnosed with schizophrenia. African Americans are overrepresented in state hospitals for schizophrenia in particular. Potential reasons for these ethnic disparities: it could be that African Americans are more prone to the disorder. It could be that there is clinician bias if there is a majority ethnicity clinician making this diagnosis for an African American patient. It could also be that there is an economic root to this. As we've said before, economics play a strong factor with mental health, especially for schizophrenia, and there remains a disparity between African Americans and white Americans for economics. Patients in developing countries tend to have better recovery rates than in developed countries, and this could be because of their collectivistic versus individualistic culture. It could also be because they have a greater tolerance for the symptoms of schizophrenia. Social labeling is something that we've discussed really from the beginning of this text and course. So the idea here is that creating the label also creates a self-fulfilling prophecy, that now that someone has an actual title for what they're experiencing and also knowledge of other symptoms, that they go ahead and fulfill that role. It also means, though, that once a label has been placed, that there could be biased treatment, meaning that particularly with schizophrenia, because it's one of the most severe psychological disorders, that there may not be as much attention or actual treatment given. And then family dysfunction. We've seen this come up pretty regularly as well with other disorders we've discussed. So the research shows family stress plays a role, and that parents of people diagnosed with schizophrenia have greater issues with conflict, with communication, and criticism. Families with greater expressed emotion, so this is negative expression of emotion, particularly criticism, yield poor recovery outcomes for people diagnosed with schizophrenia. And the research hasn't clarified what their precise causal relationships might be, but we can see that there is one. So for much of human history, people with schizophrenia and other severe mental disorders were considered beyond help, and that's not entirely different now, but we do have some other methods. So an accurate diagnosis often occurred previously, and may still happen now in some cases. Though schizophrenia is still extremely difficult to treat, the discovery of antipsychotic drugs has enabled people with the disorder to think clearly and profit from psychotherapies. So in the past, institutionalization was the main method of treatment. It began in 1793, and this was during a time where moral treatment was in place. In the US, states were required to establish public mental institutions for the poor, but this requirement typically led to institutions that were overcrowded, essentially human warehouses. For more than half of the 20th century, people with schizophrenia were institutionalized in public mental hospitals. The primary goal was just to restrain and to meet basic needs. In the 50s, clinicians developed two institutional approaches for chronic patients. The first was milieu therapy, which is still widely used today. This is a humanistic approach, and the idea is to promote a climate of self-respect, responsible behaviors, and meaningful activity to aid in recovery. Token economies, which are less frequent now but still used in some places, were established to reward desirable behaviors with tokens that could then be exchanged for goods or for privileges. Questions have been raised about these programs, particularly because of the token economies, but the research hasn't been quality for us to be able to come to really clear conclusions. As I said, token economy programs are not as widely used now, but milieu therapy is widely used. So as we saw with some other disorders, the introduction of antipsychotics made a huge impact on the way that schizophrenia was treated. So in the 50s, development of these drugs led to prescription for these drugs. So two categories here that are typically used for schizophrenia for the traditional kind of first class of drugs. So phenothiazine is an antihistamine. It was typically used to calm surgery patients prior to being used for schizophrenia. And chlorpromazine was tested successfully on patients with psychotic symptoms and approved in the US as Thorazine, which is still now widely used. The second generation of antipsychotic drugs were developed in more recent decades, so think from the 80s forward or kind of late 80s forward, and they often function similarly with different side effects compared to conventional or earlier drugs. The research has shown that antipsychotic drugs reduce schizophrenia symptoms in at least 65% of patients. In most cases, the drugs produce the maximum level of improvement within the first 6 months of treatment. So the extrapyramidal effects, these are disturbing movement problems. They include Parkinsonian symptoms and tardive dyskinesia. So for Parkinsonian symptoms, it's exactly what it sounds like. So these are reactions that really closely mirror the effects of Parkinson's disease. And tardive dyskinesia, this is one that actually people complained about the most, patients would complain about the most, and it's very visible for other people as well. So these are typically going to emerge after a year of drug use, and it's involuntary writhing or tic-like movements of the tongue, the mouth, the face, or the whole body, involuntary chewing, sucking, lip smacking, jerky movements in arms, legs, or the entire body, for example. The newer antipsychotic drugs tend to produce fewer of these effects, though sometimes the tardive dyskinesia is still present. So for psychotherapy, it's very tricky to use psychotherapy for schizophrenia unless there is stable drug treatment in place. The most helpful forms of psychotherapy are often combined therapies then. So there's the cognitive behavioral therapy, and then two broader social-cultural therapies, which are family therapy and social therapy. Under psychotherapy, again, it's a cognitive behavioral approach, and the techniques are to help patients change how they view and react to their hallucinatory experiences. New wave cognitive behavioral therapy helps clients to accept their streams of problematic thoughts, gain a greater sense of control, become more functional, and then move forward in life. Over 50% of persons recovering from schizophrenia and other severe disorders live with their family members, so family therapy can be very significant and meaningful. Living with the family members tends to create a great deal of stress for the entire family, and this means that of course, that they're going to be at greater risk for a relapse in their recovery, particularly if they're in a family structure with that high level of expressed emotion that I referred to earlier. Again, this tends to be being very intrusive in each other's lives, very critical of each other. So the goals of family therapy are to attempt to address these issues, to create more realistic expectations, and provide psychoeducation about the disorder. It may also involve family support groups and family psychoeducation programs. Social therapy addresses social and personal difficulties in the client's lives. It includes practical advice, problem solving, decision making, social skills training, medication management, employment counseling, financial assistance, and housing. And it reduces rehospitalization because it's addressing very kind of practical needs. In the community approach, which is the broadest approach for the treatment of schizophrenia and other severe mental disorders, the idea is that the community comes together to provide aid. Particularly for schizophrenia, though, mental health in general, this had some devastating consequences from a legal and social perspective. So in '63, Congress passed the Community Mental Health Act. So it provided that patients should be able to receive care within their own communities rather than being transported to institutions far from home. Very great idea. What ended up happening, however, though, is that it led to massive deinstitutionalization of patients with schizophrenia. So literally, they opened the doors to institutions throughout the country and released people. The problem here is that, as we've said before, there's a really strong impact for the course of treatment for people who have support, familiar support that is positive, versus people who don't have familial support at all or any other resources, or have familiar support but it is not positive. So essentially what this did is create a revolving door syndrome, a cycle of release from institution and then shortly thereafter readmission to institutions. So effective community care looks like this. There is assertive community treatment, which is a combination of services that include medication, psychotherapy, help in handling daily pressures and responsibilities, guidance in making decisions, training in social skills, residential supervision, and vocational counseling. Other key features are coordinated services, short-term hospitalization and partial hospitalization when necessary, supervised residences, and then occupational training and support. When this isn't in place, however, again, it creates devastating consequences, not just for the individual, but for the community as well. So in any given year, 40 to 60% of all people with schizophrenia receive no treatment at all. The two factors that are primarily responsible are the poor coordination of services and then the actual shortage of services. The biggest impact that we've seen, particularly because of the legal action in '63, is homelessness. So when people do receive treatment, it's often at a community center that is overrun and under-resourced. This means that follow-up is typically not adequate or that it doesn't happen at all. And then again, remember that everyone released from these institutions didn't have somewhere to go. So there is a huge homeless population that is also suffering from mental health disorders. Schizophrenia appears to be very high among them. So just a snapshot here of where people with schizophrenia live. About 34%, the largest group here, is living unsupervised. So that means they're living alone. About 25% are living with family members. About 18% are in supervised living, which has been shown to be very effective. About 8% in nursing homes, about 6% in jails and prisons, about 5% in hospitals, and about 5% homeless. Effective community care can be a major feature of treatment for assisting in recovery from schizophrenia. And several national interest groups, including the National Alliance on Mental Illness, NAMI, have formed a push for better community treatment. And today, community care is a major feature of treatment for people recovering from severe mental disorders in countries around the world. This does include in the U.S. There's a little area in New York, actually, an apartment complex that they have done some experimenting with. And you guys may remember early in the course we talked about the city of Geel in Belgium. They have a very similar approach to what they're trying to do now in New York with this apartment complex, where they're trying to allow people with severe mental health disorders, many of them who are schizophrenic, to reside among people who do not have disorders, but in a very strongly community environment. So people are encouraged to connect with each other to provide support for each other. And that seems to be working very well. It certainly has for centuries in Geel, and we'll have to wait to see what the research shows years from now for that area that they're trying in New York. All right, so that is the chapter. If you need kind of additional practice, or if you want to practice before you take the test, I would recommend the learning curves. They're not required, but they're always there for you. There's also the clinical choices assignment that you can look at as well. Again, not required, but there for you.